Hello.
Good morning, everybody, and we are all very welcome to the second General Scientific Meeting, Emergency Medicine Society of Ghana, EMSOG for short. Before we start, or as we start this morning's proceedings, we would like to start, of course, with a word of prayer. It is my honor to invite our emergency nurse specialist, Priscilla Alote, to give us the opening prayer for this morning. Shall we welcome her with a round of applause?
Thank you very much. Shall we all be on our feet, humbly, and let's pray. Heavenly Father, we are grateful so much for this opportunity to meet us, technical people whom you have blessed with knowledge and skills to discuss issues concerning your mandate in our lives. And as we are gathered, may your spirit be with us, grant us wisdom, understanding. Let every discussion bring insight into whatever your plan is for our lives and for our nation, Ghana. May it go well with us, begin with us, and end with us successfully. We thank you in the mighty name of Jesus, we pray. Amen.
Thank you very much. As we begin the day, a few housekeeping pieces of information. The washrooms are located to my right and to your left, so you can just go through these doors past the secretariat and they can direct you to the washroom for both males and females. As always, we crave your indulgence and ask that all cell phones either be switched off, put in airplane mode, or put in silence mode at the very least. But we hope that we engage your attention enough that you are not distracted by your phone and especially by social media. Thank you very much. As we begin today, we start off our conference with a plenary session, and it is only right that we start with one of the very first emergency physicians produced in sub-Saharan Africa. I stand here privileged to introduce as our first plenary speaker, Dr. Chris Kweku Opong. Before he takes that microphone from me, let me run away. He is one of the very first emergency physicians and fellows of the Ghana College of Surgeons for Emergency Medicine. He is also a pioneer in the American Trauma Life Support training here in Ghana. Dr. Chris Opong currently serves as the head of department for the Accident and Emergency Directorate for Konfanochi Teaching Hospital, having risen through the ranks, serving under every possible capacity. He is more than qualified to start us off today as we begin our conference with another round of applause. Please, he's my fellow. Clap for him as we welcome Dr. Chris Kweku Opong.
Thank you very much, my hype woman. All right, good morning. I've already been introduced, so I'm not going to say much. I'm here to speak to you on something that all of us are aware, a national issue, aka Galamsey, legal mining. And I'm going to approach it from the angle of our work. So, the burden of illegal mining, agency departments. So, how are we feeling it? How are we feeling the effects? That's what we're going to discuss, or I'm going to talk on this morning. So I'll briefly talk about the drivers of illegal mining in Ghana, the environmental impact, and occupational injury patterns, toxicological threats, and also discuss how emergency medicine can contribute to surveillance, advocacy, and policy. So I want to start with this case that I saw not too long ago. 28-year-old illegal miner from Western region, presented to the emergency. He was having tremors. He had dysarthria and ataxia. So, well, he thought he was sick. So he was actually referred. So after evaluation and a good occupational history, and with my knowledge on mercury poisoning, I thought it was mercury poisoning. So we decided to investigate. And well, not many of our labs can do blood mercury, but well, some of the private labs, they do it. So blood mercury was around 210. And you know, you don't want it to be more than 10 anyway. So if you have 200, then you know it's quite high. So, well, then I tell him that this is what I think what you have. This guy tells me that any medication that I can prescribe for him, no matter the cost, he was willing to buy it. And I was like, Atasa, it's too late. You know, when it's acute, well, you can have medications dealing with it. But when it's chronic, and his signs and symptoms are signs of chronic toxicity, it might not do much, even if you have the antidotes. And the other problem is that the chelators, they are not widely available. For during that period, I couldn't get some in Kumasi. Recently, I think one pharmacy shop. Then those of you who are in Kumasi, I'll have to tell you, GoPens. GoPens is the only one that has it currently. Most of the shops will not have it. So if the Galamsey, has come to stay, so if they come, just remember that you can help them. And this is not the only patient that I've seen with the toxicity. I saw another one. He was having dysarthria. And with my previous knowledge, I remember I told him that when I saw him, I was like, before I could even take a detailed history, I just went like, do you do Galamsey? Then it's like, Dr. Wallahi, oh yeah, so another case of toxicity. So they are coming to our emergency department. And the important thing that we all need to appreciate is that the emergency unit is a window on the society. Whatever is happening in the community, it normally plays out at the emergency unit. That is why we are supposed to pay attention as emergency care workers and pay attention to these trends so that we can also inform the public health people to act. So when we talk about illegal mining, what do we mean? We all know what it is. It used to be gather and sell, where those times in Konongo and all those places, they were digging very deep to go and get their gold. But now, with the help of machinery, they've turned it into something else. It's very labor-intensive. Normally, we describe it as artisanal and small-scale gold mining. And the problem that we are having now is that even those who are licensed as small-scale miners, you and I know that they are doing Galamsey. And even if they are not doing Galamsey, their activities can also be detrimental to the environment. Even the big ones, the Anglo Golds and the Newmont, their activities are still detrimental to the environment. Just that they put in an effort to try and reclaim the land. And that is what we are not getting from our small-scale miners, because if they attempt doing that, they believe that their profits will become small, so they won't do it. They do it without any protection, no PPEs, no health surveillance, and all that. And the problem is quite big. So I'm showing you a map of Ghana. So the yellow part, Galamsey is occurring everywhere. The name Gold Coast has become relevant right now. At first, the Gold Coast was really not Gold Coast, but now the whole country has to be renamed because everywhere there is gold. So I think it's OT and Volta that is not having it. And by the time, when they start discovering it, I promise you, they will also be yellow. But for now, 14 regions, they're having illegal mining. And it's estimated we have about 1 million people being involved in this, about 4.5 million families or dependents. And I remember I listened to the president. In fact, my first one was the former president, President Kufuor. He was being interviewed about this, and it's like, well, there's gold all over. Man is poor. What do you expect? They won't die. There's a survival instinct. They will not starve and die. They will do it. But we just have to make sure that we do it properly. And President Mahama also recently told us that we have to make a decision. We have to make a choice. Whether you know that, you know that some of the small-scale mining is contributing to a boom in the gold production. Either the dollar will drop or our environment will be damaged. We'll have to choose one. So when I'm done, I'm going to find out which one you're going to choose. All right. So from Galamsey to the emergency department. So whatever is happening at the Galamsey site, we have the repercussions coming to us. And like I said, it's very difficult to control because of youth unemployment and high gold prices. Gold prices are very high. I don't know whether the devil has decided to make the gold price high so that it's become lucrative. So now it's very difficult to control, and the environment being destroyed, coupled with all these occupational hazards, the trauma that we are seeing, the dust, the violence. There are so many gangs now. They control territories. The recent one, there was this guy, Kwame Ato. Kwame Ato, who knows Kwame Ato? So these gangs, they also fight and they contribute to the injuries and all that. And another one that I mentioned already, the toxic exposure to heavy metals. So they have to use the mercury to kind of, they call it amalgamation, try and get a gold, you understand? And I think most of them don't know how hazardous the mercury is. They are using their hands, they are burning it, they are inhaling it, and all that. And some are also using cyanide. In fact, even the cyanide is also used by the biggest, companies as well. And these are very, very toxic. And the activities also lead to other heavy metals being released into the rivers and also the soil. All right. So on our side, as clinicians, we are also having the effect. The respiratory diseases, the infections, the renal failures, and all the like. So that is how the Galamsey is moving to our emergency unit. So this is a real picture in Ghana. And you know, when they go to the forest, nobody will see them. If you want to go there, you need a helicopter. And you know, nowadays, if you want to be on a helicopter, you have to pray. So, so at times they go there and hide there and do whatever they want to do. It's difficult to really manage, but they are destroying the forest. 34 major forests significantly destroyed. The sad aspect is that the food crop, the cocoa, they'll just cut off your cocoa. If you make noise, they'll pay you off. If you don't accept the money, well, they don't care. But it's a food security issue. So very soon, we will be struggling to also get food to eat. And even if you get the food to eat, it's actually loaded with heavy metals. All right. So all these excavations will result in what? Open pits that are left unrehabilitated. And mind you, can be rehabilitated. You can cover it and grow coconut and all these. You can reclaim the land, but it's expensive to reclaim, so they won't do it. It will serve as a breeding ground for mosquitoes, so you'll be having a lot of malaria and severe malaria coming to you as well. And people will be drowning in it. Even the military, the soldiers, some of them are drowning. When they try to go and do galam stop and whatever, they get drowned. And the children are drowning. They are falling into the pits. The farmers, you have your farm, somebody has dug under it. You're going to fall into a pit. The water bodies, and those of us who travel around the country a lot, anytime I travel around the country, I become sad because I have not seen any clean major river in the country in a very long time. All of them are like this. The Birim, the Pra, the Ankobra, the Tano. This is what is happening. And it's not just brown, it's laden with what heavy metals as well. And at times I wonder what the inhabitants around it, because their major occupation was what, this fishing and all that. So now I wonder what are they doing. Then I believe that they are also doing galamsey, because now there's nothing else to do. Because, but the other issue is that if you're going to eat the fish, they might not survive, but if some of them survive and they come and sell it to you too, they're also in trouble. They'll say, the social media people say, atasa. So, so you have to also watch out. Whether you are there or not, the value is the same. Stagnant water, and there's no good water for local, what do you call it, food preparation, for washing and all that. And when we have such a situation, cholera cannot be avoided. We have all the other diarrheal diseases and also typhoid fever. So chronic exposure to the heavy metals too results in kidney disease, not just the kidney, even the heart and all the other major organs. So it's not just mercury that is exposed. You also have arsenic. You also have lead. All these heavy metals are released into the environment, and there's been a lot of studies that have confirmed this, and a lot of researchers have gone into details, going to take samples from the mining areas around Takwa and all that to confirm that we have high levels of these toxic metals in the river bodies and the ecosystem. All right. So mostly young people are the ones, young men, you know, the boy child. They're always involved in all these risky businesses and all that. But it's not just them. As you can see, they are busily washing. If you know washing, who has done galamsey before? If you know washing, you know what. So child labor, all these young children are being exposed to these heavy metals. Very, very unfair. The child rights people should come in. And are women also involved? Times when you see the women really deep in the mud, you wonder what is happening to them. All right. There are no PPEs, and also very, very dangerous. So I'm showing you real pictures here, galamsey-related injuries. This is a gunshot, you can imagine. And the gunshots, they get it from themselves, the rival guns, and also what? The security forces. So if you are good with forensics, you can imagine which gun this might be. Who can guess? All right, just guess it. So you realize that the injuries are global in nature. If you have eyes and you pay attention to the skin, you can predict the nationality. But it's a global injury phenomenon. So this one too was at the emergency. At times, a lot of people attack the site. So they get what they call tip-off that, well, the gold is ready. Then they attack the site and they go and get it. Even there are times that some of the military or the security forces are also involved in these attacks. So as for, that's why they are, if you are wondering why they are armed, that's why they are armed. Because if there is gold and you don't have arms, they will come for them. All right. So most of the time, the injuries are as a result of the machines and the equipment that they are using. About 46% of them, according to some studies. So you realize that annual injury incidence in the small-scale miners is very high, about 289 per 1,000. So they have a lot of injuries, but they don't give up, as I said by Tija. So they have all these amputations, crash, cuts, and the falls. They're always falling in the pits, and the pits are always collapsing on them. They're having spinal injuries, cervical spine injuries, very, very common. We see them. And they get asphyxiated, and the gunshots too are there, and all that. So, long bone fractures, you can see these were all small-scale miners. Let me be politically correct. Small-scale miners, or galamsey. All right. So, long bone fractures, pelvic fractures, crash injuries, all kind of injuries, very, very bad ones. And they are using explosives. They get all these blast injuries and all that, falling from the height, blunt abdominal injury, penetrating abdominal injuries. They fight a lot. So interpersonal violence, they are drowning into the pits and all that. And the occupational violence, the firearms, both from the security services and themselves. Unim red. All right. So, the work is hard, difficult. You cannot just get a goal. You have to work hard. So they get tired. So they rely on a lot of stimulants and to make them feel invincible. And so the weed, the wooden red, all kinds of drugs. They take all kinds of drugs, recreational drugs. And at times when they get the money, when they get a lot of money too, they want to be happy. So they also continue with the recreation. So it is leading to a lot of, substance abuse and all that for different reasons, both for strength and all that. And also with the respiratory system, chronic exposure to dust and all these is causing a lot of respiratory illnesses, COPD, silicosis, pneumoconiosis, TB, lung fibrosis, and all that. And the work too being hard is also leading to what? Back pain. That's what the back pain there. I have a friend who is involved in that. He's always complaining to me. And my knee, my back. It's like, you ain't seen nothing yet. The whole body will break because you go and do this hard work. You want to be strong. So when they come to you in the hospital and they are complaining of back pain, and you should know that that's where they are getting it from. Or the awkward postures. They have a way of entering the underground pits. And very, very, at times I wonder whether they are superhumans. And all the noise and the vibrations too. Have issues with the ears, the explosives, they don't wear anything, they might lead to ear damage. So the substance abuse also is leading to mental illness. So when you have patients coming to you with acute psychosis, just take a little bit of the social history and you realize that they've been abusing substances to make them work harder at the Galamsey site. All right. So this is how mercury is exposed. Some inhale them, some through the skin and all that. So they get all this chronic exposure and they have all these, So a study was done in Takwa, Prestia, and they tested their urine and blood mercury levels in these miners, and they were very high. And the residents as well, they were very, very high. So as for the chronic exposure, people are being exposed. If you have a chance, you can test yours because you've been eating fish, you've been eating the staples. You never know whether you're also being exposed. All right. So with the mercury, you see how they handle it. They are constantly being exposed. So they might be acutely exposed and present to you in an emergency or be chronically exposed, like the one I mentioned anyway. So when they inhale the vapor and all that, they might present with cough, dyspnea, chestness, a tightness in the chest. It might progress to chemical pneumonitis or ARDS. So, or they may be having nausea, vomiting, abdominal pain, and they might present with an acute kidney injury, hematuria, or a headache, tremor, irritability, and all that. So high index of suspicion, taking occupational history, you might probably narrow it down to an acute mercury toxicity. For the chronic ones, it would have deposited in the brain, so you'll be having fine tremors, ataxia, peripheral neuropathy, excessive salivation, insomnia, mood changes, hypertension, kidney dysfunction. So these are some of the investigations that we should be doing, looking for to try and diagnose our patients. So this picture is just showing you a patient with chronic exposure. Look at how the lungs are looking at now. So it is not a good thing. At a point in time, you can't breathe. When they come, don't say it's pneumonia. They've been exposed to, or TB, because it might just be mercury exposure. So take a very good history and find out where they are consuming fish, use of mercury in workshop. And in the hospitals, God being so good, now we are facing out the mercury. I remember there was a day I was on duty and one of the mercury thermometers and fixed. Well, it hit the floor and the mercury came out, you know. So it's toxic anyway. So I think I ran away or something. I don't remember. I don't know how we dealt with it. I don't remember. All right. So do a very good neurological exam because the chronic ones, they'll be having a lot of CNS symptoms. The basic investigation, CBC, LFT, because they'll be having kidney function, renalysis, ABG for respiratory distress, blood or urine mercury levels. And like I said, our labs are not doing it. Most of our labs are not doing it, but some of the private labs are doing it, so we can do that. But I remember yesterday, before this presentation, I spoke to our lab, head of the lab, like, what is preventing us from doing these tests? Oh, well, it can be done. So they are working on it. So all of us, we should take a cue from it. We might have to start letting our labs doing it because as for the small-scale mining, all right, it's ongoing. All right, so okay, so it will be controlled. That one, rest assured, but it's still ongoing. All right. So if you have such a patient, well, emergency people, you know what to do, ABC, resuscitation. But if they have an acute exposure, chelation is something that you have to think about. Saxima, dimercaprol, bile. And penicillamine too can also be used. Unfortunately, it can be used for lead, arsenic, and also mercury if you have the chelator. And it's not too expensive anyway. When I asked, I think it was about 100 cedis per vial or something. I might give several vials anyway. All right. So you have to just use it. But if it's chronic, it will not work that much, but it will mop up the one in the bloodstream. It doesn't cross the blood-brain barrier. Unfortunately, when it's chronic, it would have crossed the blood-brain barrier, and the chelators are unable to cross it. All right. So arsenic, cyanide is also being used. So they can also come with cyanide toxicity, headache, confusion, seizures, dyspnea, arrhythmias. They will have lactic acidosis, might desaturate, and all that. So high index of suspicion. Make sure you also protect yourself, and what do you call it? You're going to give oxygen, the correct acidosis to treat seizures, and also administer the antidote. Hydroxycobalamin is available. The Sinocate. Normally, if you are not getting it and you are close to any big mining site, call them. They will give you some. So, as for the antidote for cyanide, is available. All right. So arsenic also will give you GI symptoms, diarrhea, abdominal pain, hypotension, shock, cardiac arrhythmias, chronic exposure. You'll be having hyperpigmentation, hyperkeratosis, peripheral neuropathy. They also predispose, they might lead to cancers, lung, skin, bladder cancers, anyway. So aggressive fluid resuscitation will be needed. Chelation therapy, like I said, the Saxima, the dimercaprol, they all work. Penicillamine too also work. Monitor for arrhythmias and all that. So our children are being exposed, the vulnerable population, the women are being exposed. I think there are lots of advocacy that has to be done to try and control this. And the other sad part is that the non-mining communities are having their fair share because downstream, you'll be minding your own business somewhere, they would have polluted it. I remember Cote d'Ivoire was complaining some time ago that we are polluting our water and the water is going there. All right. So we have gaps in our health system to really meet the demands of these, problems. Pre-hospital, if I may ask, have you responded to a forest Galamsey site accident before? You can't reach there. In fact, access is even a problem. So when they have these multiple casualty stuff, pit collapses, they have to I don't even know what to do. They'll come up maybe in pickups and stuff, taxis and motorbikes. So they don't even get pre-hospital care anyway. At the emergency unit, we don't even have the right chelating agent. We don't have the chelating agents. We don't have them. I've asked around. Nobody has it anyway. We don't test them. So, plus are overcrowding. So it's quite challenging. But I think it's something that we have to know as managers. Some of you are managers. You have to try and start getting them, the drugs, the antidotes into the system. We also don't have good data. Well, before this presentation, I was trying to get data. Well, the data, as for our data for now, it's been suspended. But we'll get the data very soon. But if we get the data, the problem is that we are not even coding them as mine-related. So probably we have to start registries where we will have to code them properly. All right. Weak linkage between health sector, Minerals Commission, EPA, security agency. So there's no coordination. The health sector has been left out in this Galamsey fight. Nobody is talking about it, but I believe we have to involve the health sector. All right. So what can we do as emergency people? So at the bedside, take a very good occupational history. We have to build simple protocols for the ED when it comes to mercury, cyanide, arsenic exposure. Make sure we document the occupational history properly. The hospitals, if we can, establish registries for mining-related emergencies. We have to be doing a lot of simulations and training drills on these mines. When you go to the gold mines, they do a lot of simulation on cyanide, for example. We have to also do the same anyway, because you should know exactly what to do when you encounter such situations. And advocate for stocking of essential antidotes and the PPEs. Because when they come and you're also not well protected, you can also be equally exposed. And we have to partner with the public health and mining regulators and NGOs for surveillance and prevention. We have to contribute, in terms of research, we have to give data to the public health people so that we can properly address the health concerns as well. So I believe some of you might have heard about the Minamata Convention. So the Minamata Convention, the aim is to stop the usage of mercury in this artisanal mining. They have other alternatives. They have these gravimetric methods and all that. Because the mercury toxicity, mercury is too toxic. So Minamata disease, if those of you who know Minamata disease, in Japan, there was a company that was pouring methyl mercury in the sea. And the fish were also getting absorbed. Then people were eating the fish. And you can imagine, they were all having attacks there, the whole town. Everybody will be doing this, you understand? So, and that led to this Minamata Convention where the advocacy is to stop using mercury in all these stuff. At least there are other methods. We should just advocate for that. Advocacy. That one, we got talk tire. So the health impact assessment, we have to champion alternative livelihoods. The alternative livelihood, the difficulty is that, you know what I'm talking about. The money is small. But we'll still have to continue educating our people. I think the key message that we can get from today is that the illegal mining, the effects of the illegal mining are being seen in our emergency department, and we have to be prepared and should be ready to deal with them. We are the sharp end of the long chain of environmental damage, occupational hazards, and also the toxic exposure. We are seeing trauma, we are seeing respiratory failure, kidney disease, neurotoxicity, and all that. We have to contribute to the data. At least we should have data to really address these issues. And any national response or issue should involve the ED so that we can properly give a very, very good perspective and also to prepare adequately to address the health needs of these small-scale miners, because they are also Ghanaians. Any questions? So maybe the questions will be later, but I will conclude by talking about the fact that the story of Galamsey is not only written in the bush or the rivers, it's also in our resuscitation base, the trauma theaters, and the dialysis units. So we should all contribute to the data, and also as policymakers, we should also think about it, that we have to also include the health aspect of fighting Galamsey. It's been ignored for now. Thank you. These are my references. All right.
Thank you very much, Dr. Opo. So please, if there are any questions, you can please come to the center and just address the House using the microphone provided.
Or contribution, anyway.
Questions or contributions? Yes, please.
All right, thank you very much for throwing light on the galamsey issue in the country. About a month ago, we saw one case in Kolebu. And as you started talking about galamsey, then it struck me that we normally don't keep data. But luckily enough, we still have the patient on admission. So it had just caught my attention that we should go back. Really, we knew where it was coming from. It was from the galamsey side. He had respiratory complications from it, and he has to stay on oxygen for life. We've counseled him, but unfortunately enough, the team managing him, because we give to the respiratory team, I don't know whether that they've given him some hope. So when we even wanted to discharge him on oxygen, counseling the family, he resisted, saying that they had taken some tissue sample to South Africa and that a solution will come. But we didn't want to fight it. So my only advice is that as emergency physicians, wherever we find ourselves, even far away from galamsey sites, when the cases come, as he said, we should try and probe more into it, and then we should keep the data. The other suggestion would be how, as emergency physicians, even if we don't have the national data yet, among emergency society, how best we can start sharing some of this data with colleagues in all areas, including the remote places, so that to encourage all of us to keep more data, and then we can also contribute to fight this menace. Okay, thank you.
Thank you very much. Any other contribution?
Mine is a question, actually. You mentioned the registry and the coding. I was just trying to check on the internet whether there's ICD-10 code. I'm not sure whether somebody code for galamsey related, because that's how we are storing our data. So I will discharge as respiratory ARDS from what? So if we are not able to code it in ICD-10, then we will lose that data. So I think we need to go back to that basic point where if we are discharged, we are able to code it as mining-related disease. And then when we pull the data, then we can actually get that. So maybe you need to revisit the biodata system we use as a country and as institutions to actually get that data. Yeah.
Yeah, I agree with you, because if we don't code it properly, even if you go into the database, you cannot tell which one is a mining-related injury or not. All right, so that's why I also mentioned the registries. Well, it takes money, but if you have a mining registry too, probably we can also get the data. And that is where we'll have to have external help from the bigger health, the Ministry of Health, from the Ghana Health Service. And that's why I was looking in this direction. All right, any other contribution? All right. All right, go ahead.
Please, I'm a medical student and I just joined during your lecture.
Right.
I would like to ask, what would be the key takeaway for us medical students who are yet to see this? Probably in the next few years when we enter into the clinic setting, what would you want us to know and what would you want us to pay attention, especially with treating them and managing such cases? Thank you.
All right, so since you are almost done, or you'll be coming out soon, I believe you will be the ones attending to these patients. I would have been on retirement. I'll be on retirement. So it's very important that you have a high index of suspicion. And I think one take-home message is the history. The moment you're able to take, if you don't jump, if you don't skip steps, the house officers will understand, you will not understand. And you take a very good occupational history, you will always pay attention. The moment they tell you that they are small-scale miner, or where they live, you know that they are small-scale mining activities. You start paying attention to exposure to all these toxins, from lead to arsenic to mercury. And by the time you finish, I hope that our labs will be ready to be testing these as well, so that you can investigate and confirm your diagnosis as well. So high index of suspicion, taking a good history, and also hoping that by the time you are done, we would have stocked the pharmacy with all the antidotes as well. Because, so do your part, we'll also do our part. Thank you. All right. Or you can use this one.
Thank you. I want to ask a question. From your presentation, At the beginning, you made mention of availability of antidote now, though it's not common. I know for the pharmaceuticals, it's a business, so very soon it will be all over. But my problem is the testing for the mercury. It's very scarce. I'm coming from Volta Regional Hospital, and we don't have. We are not able to test for it. So if a patient presents with the symptoms, with a history, and is suggestive of that, will you recommend we start the antidote even in the absence of the testing?
Well, I think with a good history, you should be able to have a very good, reasonable suspicion. And we've been doing that all the time. With malaria, with everything, you can treat. You can always treat. When you have a very good history and high index of suspicion, you can treat. All right.
I think should work. You know.
So thank you very much, Doc, for such a wonderful presentation. My question, I think, at the course of your presentation, you mentioned that when it comes to galamsey issues or mining-related issues, the ministry is neglected or has been neglected from tackling or speaking about this problem. And you know that the canker of this is no respecter of person, wherever you can get it. So I want to ask what actions the ministry taking, or the doctors or the Ministry of Health or the Ghana Health Service taking to get the ministry involved in echoing our voice to educate the masses on the impact of this canker.
Thank you very much for the question. But you know the question, I cannot address the question. But I have able men and women here. I don't know whether any of them will want to volunteer. Probably there's a policy from the ministry addressing small-scale mining-related injuries and also toxicological presentations. I'm not aware of it. But if there's anything like that, I'm referring to two people, they know themselves. They might address. If there's nothing, then we'll all go and find out. All right, so, and that is what the point I was trying to make. All the money is going to NIMOS. They have to give us some of the money for the databases, for the registries, and also to buy, what do you call it, the collating agents, and also to establish the labs. So if you are here and you're a policymaker, listen to, go and speak on my behalf. I think that we have a wing of NIMOS in the emergency department that we can also help address the problems arising from the mining sites as well. It should be a comprehensive approach to solving the problem. All right. Okay.
Looking at the way the poisoning can be chronic or acute, when do you know to treat? Would you just base it on the symptoms? Maybe acute has vomiting, chronic has CNS, so this is acute. I'll give a chelator to see if it works. This is chronic. Or is there like a time frame? If the symptoms have persisted for a week, treating is no.
All right, so the chelators are mainly for the acute, but you still give it for the chronic. Because when you give it for the chronic, it's able to mop up the ones in the system. It's not going to mop up the ones that has caused the blood-brain barrier. So the damage is permanent. But at least you still have a lot of, agents in your system, because there have been studies to show that when you even give it for the chronic and you are testing the blood and the urine, you realize that the mercury will be dropping. And you need that, because otherwise you will have further damage. All right. But you have to educate the patient that they shouldn't expect marked improvement. They might not get better with their symptoms. But, well, there's still physical therapy that can be done for the patients to help improve symptoms such as dysarthria, the ataxia, and there's a physical therapy for that one as well. All right. Yes. You can come. Now it's better.
We've solved all the issues with the microphone, so you can come and use it.
I wanted to know if in testing, do you have to do the blood or the urine, or both of them?
All right, so you can do blood and urine. You understand? When you are doing urine 24-hour urine collection, and I think that's more cumbersome. So depending on what you have, I think you can do both. You understand? So depending on what is available, you just do it. All right. Yes.
All right.
President,
thank you for
let's
such
do it,
an insightful presentation. I wanted your opinion on, as part of surveillance, and also because there's a very fine relationship between public health and emergency medicine, what is your take on routinely evaluating every miner for mercury or cyanide or arsenic toxicity? Is this something that you propose that we do it at the ED for everybody who presents with a suspicion or a history of mining?
All right, thank you. So a lot of investigators have attempted getting samples from these miners. And when you go there, you and I can imagine what will happen. They are not very cooperative. They are very suspicious and all that. So I believe the NIMOS health wing that I was talking about, if we have that one and we have funding, it's something that we can do. We'll have to talk to public health and do surveillance to see in the hospital, because we see them almost every day. And I think it's a very good opportunity for us to do the surveillance. So I think when we all go back, we'll talk to our public health people to see whether there's some funding for it, or we'll look for funding to try and look at that, because that would be very, very helpful to really confirm what we are seeing. In fact, I was looking at a study that they want to initiate. We are always saying that it's causing renal disease, but if you read the literature, you realize that nobody has been able to really link it properly. You understand? And it's because we've not done a lot of in-depth studies into it. So these are the miners. We did this test, and that is what we are seeing. All right. Exactly. So I think the screening will help a lot. We're able to catch them early. Then they don't progress to the chronic stage, because when they get to the chronic stage, not much can be done. And remember my boy that I saw earlier, he was saying that whatever amount that it will take, he is willing to pay. Then I gave him the answer, Atasa, your money cannot help you. You understand? So if you catch them early, that will be very, very good. All right.
All right. Sorry that I'm talking for the second time.
Yeah,
right?
talk.
So I believe
I don't know whether
conferences like this, one of the things is that we come out with some solutions and suggestions. So as emergency physicians, I just want to suggest and see if this will work. I mean, the Galamsey fight, we know that the health sector has not been included, but we can make a case for it. So I just want to find out, if it is not possible, I don't know if you know the cost of testing the heavy metals, because you have done some before for the mercury. I don't know if you know the cost. But then if we suggest to Ministry of Health or to government, instead of just testing the people in the mining areas, we should do a nationwide testing for some of the heavy metals, because it looks like we don't understand the impact of this mining on communities that are mostly not in the mining areas. One thing I realized is that I've been coming to Kumasi a lot, and when I come, there's a hotel where I lodge. And the last time I was complaining to someone that the water in Kumasi, I don't know whether it's Kumasi or in that hotel, is sweet. You know, I brushed my teeth and I felt the sweet taste. So the last time I came, I went to confirmation and I tested my sugar, it was fine. Then I bought a bottle of water and drank. It wasn't sweet. So I was concerned. My issue is that it means the water is contaminated and they are using some chemicals to treat this water, that the water is sweeter than the water in Accra. So my suggestion would be that as we end the conference, we should make a document and present to government a suggestion of testing across the country so that the impact of it will understand it well. Now we've started seeing babies that are born with deformities and all that. We still don't understand. A lot of kidney issues and we don't know where it's coming from. But when we have a data, that will speak well. So that's my suggestion.
Thank you very much. And for your information, the water from Accra has always tasted different from Kumasi. Those who know knows. That is it. And so if you've been, it's always tasted different from Kumasi. So, and I don't know why, but that is it. All right. Thank you very much. I'm out.
And a very big thank you once again to Dr. Chris Kweku Opon, our first plenary speaker for the conference. I think it was a very interesting and insightful way to begin the conference. Don't we all agree? So please, can we give him another round of applause? There will be more time for questions at the end of the plenary session, so if we haven't had the chance to address your question or contribution, please note it down so that when it is time for that, we can come up and ask our questions at the appropriate time. So, our next plenary speaker, we are going in order of when speakers went to the Ghana College and became emergency physicians. We had our very first group of emergency physicians presenting Dr. Chris Kweku-Wopon. Now we have the second group presenting Dr. Lawrence Ofori-Buedu. He is the second of the batch of emergency physicians, but he has gone far beyond that. After acquiring several, and I mean several degrees in both medicine and law, he is currently serving as the director of the Institutional Care Division and the head of clinical services for the Ghana Health Service. He is here to speak to us today as our second plenary speaker. Shall we please welcome him with a round of applause?
All right, thank you very much. They made me look an old man. But Rita is here. Rita was my senior when in medical school. So you had to come in that order of medical school is the one we call seniors. So I'm so grateful the president, Dr. OKD. We have been calling him OKD. Even if you can't professor, he's Professor OKD. So, I mean, it comes without thinking about it. EMSOG, Ghana College, our emergency representative for Funyami I told you last time he came that the first time he has visited my office, even though he has stayed in Accra for 5 years. He didn't know my office. But I'm going to show a picture where Prof. Nyami came to visit me. I'm supposed to be discussing or leading the discussion on command structures from classroom to the field and the impact of emergency medicine. I felt this is supposed to be something that we all have to talk about. It shouldn't be a long lecture, but I've been asked that it's a standard international conference, so I have to show slides. So bear with me if I'm not able to flow with the slides, but I will still be doing the narrative alongside. It's my own slides anyway. So with all protocols duly established, my name is Ofori-Buedu. I'm an SMS product. I'm very proud SMS product, who also was groomed through the Confanoche capacity building Kufu emergency as emergency physician. Your CEO will come. She is also following me. And now he has a gray hair, so anytime you people see that he's an older than me, he's my younger brother. But in medical school, we were the same class. So we were classmates for medical school. So that is the discussion I'm supposed to be leading. And I want to put emphasis on the fact that emergency care in Ghana has gone through turbulence. I have been out for the past almost 8 years, so it means for Funyami and Co are 14 years plus. And it has gone through turbulence from the first batch, second batch coming out. People didn't want to recognize that the emergency is a formalized medical training. They felt that it's supposed to be an adjunct. So when we started, we had a lot of issues. People were boxing us. You do the diagnosis, they come and cancel the diagnosis. And say, my friend, a house officer in medical team should clerk again. When the resident has reviewed. So we went through it, but it strengthened us. So it's also when you go out of the system, the same thing. We've gone through challenges over all these years. Coming from training to field recognition on the field, how you be fixed even into the older structure. Creating an emergency for you to even work was an issue. They have to pair you with some trauma team and say, this is casualty, go and work there. So all these are challenges that we've gone through. But we're forced to create departments. We're forced to work through creating referral system that is keeping our emergency system in shape as of now. So Ghana emergency system has also evolved, right? From training, as I mentioned, to clinical practice, and then to governance. And so I don't see myself to be alone. Because for so many years, governance structure, you won't see any emergency person sitting down there. Now I'm there. So when it's about emergency, whether it's our EMT or it's about Ghana College, I speak some. because that's where we wanted to get to. So anytime they call me polygas, I say, I ran away from the training. I didn't do fellowship clinically, but I ran to the place where I wanted to sit down there and talk. And so when we wanted to do policy, I said, let me go and do medical law so that I strengthen myself the legal issues. And so I think that's the arm. Everybody is moving around an arm where you feel comfortable to pioneer yourself to be at the front. So we are there to project how emergencies should be run in Ghana. And so about 2 years ago, Ghana Health Service set up to do some assessment. We wanted to do assessment to see quality of care in terms of emergency area. And so we set about 7 parameters. We're doing assessment on access, whether it is there or not, the usage, effectiveness. And so we designed what we call harmonized health facility assessment. This was done. We randomly selected all regional hospitals, about all district hospitals, health centers, and then we went down. So we took almost 1,500 facilities to assess. And the findings are very interesting. That's what I want to just project before I hit on that. What did we find? First, it was reported that there's low availability of emergency services in Ghana as you go down. As you go down from the hierarchy. So teaching hospitals have excellence. As you move down the hierarchy, the emergency services start moving down. And so it said about 65%, that's 2/3 of the facilities we assess, had some form of emergency services. Some form of emergency services. So it means that every facility, 2/3 of the whole, has some form of emergency. But as you go down, the structure keep on going down. The services go down. That was what we found. At least we went through it. Ahafo had a list. OT had some of the least emergency services. And then if you come up to Kumasi and Accra, they had the highest numbers. Now, if you go to the next item, similarly, you have 19% of facilities surveyed had 24-hour emergency. 24-hour dedicated emergency, 19%. It means that the emergency is there, but somebody, they don't always the security man who is there, who will go and call the doctor and come. So even though we had 65% of facilities providing some emergency care, 19% had 24-hour dedicated, where the staff is there, I'm waiting for you. All the rest, they have to go and call somebody, either from the home or they will give a call me when the emergency comes or something. This is the picture we had in Ghana. And then we move on to the next item, availability of guidelines. What did we find? 19% of the facilities had some protocols or guidelines, just the basic. These are the protocols we're looking for. 19% have these guidelines. I think I'm blocking you, eh? Oh, only one projector. Then let me hide in that corner. But then we came to facilities providing emergency service that has staff who had received some training. What did we find? Only 32%. So those who have been providing emergency care, if you ask them, have you been formally trained? 32%. So when somebody look at this figure and say, you who are killing us at emergency, can you say yes or no? Because people have not been trained. 32% have received formal training within the last 2 years when the survey was done. I just want to bring this into just provoke us. Then let's go on. Only a third of health facilities offering emergency service had a formal triage system. This is about triage system. So it means that we are offering it. But go and check. Are you triaging the people? That's the percentage that we had. 34. 34, that's about a third. Then we come to services, transportation. My CEO. 24-hour service. This one, we are looking for rapid access to emergency transport. 15%. Rapid access. So I went to DO and asked him, what's the definition of the rapid access? Because part of the thing we were designing. Rapid access. And so they defined the time frame. That when I call emergency EMT, the time, how do you call it? Is it response time? How do you call it? Response time. So 15%. I will come. Rapid access. No, we work with national ambulance in most of our response. Even though we have something we call ambulance in our facilities. But most of the time, CEO will tell you, we depend on them. He will show you the data, how many calls they receive from us. So we use some of the system to look at our response time. And then the last but not the least, I just want to bore you figures, even though I know it's academic session. The various level of care, we realize this parameter is missing. There is also limitation to the picture of clinicians, traumatic injury. That was X-ray. We also assess access to radiological imaging. Because if you are running 24 hours, it means that you have to have 24-hour access to X-ray. But we realize that most of the trauma cases that come, 50% of facilities have access to 24-hour imaging. It means that when you have imaging, you wait till the X-ray report come the following morning before you can shoot an X-ray to see whether you have a blunt injury or there is some fracture in there. We're looking at these parameters to look at our emergency response system. This one is documented. It's a survey. And this is what is basing on our effort now to see what we can improve as a service. And so the proposal to present, to have this presentation, the target was to look for a funding. And if you want to have a funding or to look for a solution, not only funding, that one will come. Financial sustainability is a whole issue in the emergency sector. We're looking for a solution. Before you have a solution, you must be able to list your problems. Is that not so? So we listed all this and we put them in a proposal, and it's gaining some weight. We will share it before I leave. And so, some form of capacity building, we started going down, ensuring quality clinical services within networks. We're targeting those who are at the lower level to see what we can do. We did some form of engagement. This is a slide that's supposed to be part of the solutions, because we know National Ambulance CEO is here. He has a fleet. By the fleet, he will tell us their state, whether they are all available or not. So I'm sorry for bringing it here. But actually, this is supposed to be some of the things to strengthen the initiative. We started working on a national referral policy. OKD was a consultant, in quote. These are all gaps we found. We didn't have policy, we didn't have guidelines. So we said, let's work on some of these things. Let's engage community. That's what National Ambulance is doing now, engaging community to strengthen emergency in the system. Saving lives, early reporting, what's your data? Where is emergency data in our facilities? We work on strategic partnership, collaborations. I just want to run through this because this is some of this raw thing. This is when the CEO came and said, let's partner, because I want to build capacity in the community. So CEO visited me in my office, and then we started the partnership, and I'm happy he will talk about his capacity building in the CEO. And then this Prof. Nyame came to also visit me with the Royal College of Emergency. This is all about partnership, looking for solutions, because he visited what about capacity building at the regional hospital level in emergency training, where we can move emergency training to regional hospitals. So as I sit down there, I needed to also open a way as a policy to embrace my people to come around. We started doing also capacity building at our own level, emergency care capacity building. So we have some emergency physicians who are in Ghana service supporting us to build capacity, so that we don't leave everything on EMSOG or the emergency physicians in teaching hospital, but we can all contribute to do. So we have some emergency nurses, emergency physicians, family physicians doing some capacity building exercises. I think these are some of the images about capacity building. Basic care, emergency, we partner with EMSOG to provide this capacity building, because these are gaps we picked, and we started working on these gaps. I think providers are there, they are also trainers. So I picked some of these things just to remind us that when we did the survey, we didn't just sit down. Even when we moved to public health emergency response, we thought we needed to have treatment centers, standard treatment centers for public health emergency. They are also emergencies. And so I think GIDC was built during the COVID time to provide standard emergency care, critical care as well, for infectious diseases. We are building quality trainings. Recently, we launched this quality of care report that works on how do we improve quality in emergency area. We look at universal health coverage. This is our target in Ghana. Wherever you seek to improve care, you look at what are the components of the universal health coverage. And whether it's an emergency or ENT, Rita is here, you look at what you do. Is there access? Is there quality? Is there equity? So if you can work on these three parameters, access to emergency, quality emergency care, equity, wherever you find yourself, the same practice, the same protocol is found. Then we'll be working towards achieving the target of the ministry, that's universal health coverage. So that's something that we can also think about. So how can we move forward? The command structure. We need to start from education. Very, very important. And we know the postgraduate training and undergraduate training for emergency has been in the system for some 13, 14 years now. We need to work on putting measures that residents go through EM as part of their rotation. Other than that, they will still not see us as part of the system. We only keep house officers who go through us. What about other residents? Residents from medicine, residents from surgery, trauma, do they do rotations in emergency as a compulsory rotation by the college? This is something we need to talk to the college about. I know some work has been done. Chris is here, the head of the department is here. But we need to make sure this thing becomes something we can work on. Then they will appreciate what you are doing there. We need to expand CPDs. How many CPDs do we do on emergency in a year? There are so many CPDs going on. You go there, it's a mother and child something, a mother breastfeeding, CPD. How many CPDs have you gotten on online that you can join? That's about emergency, building capacity, building systems. It's an area you can also look at because BEC has come. How often are we carrying the BEC along? Affordability is an issue. Is that an issue? How do we address that? Access, trainers. This is the time we have to think about at this forum. Very important. Then we need to expand the access, capacity building. Now specialty training is going on. That is a good thing we need to work on. We need to enter into global partnership. I must say that from where I sit for the past 6, 7 years now, I've been working with some partners who are supporting us to do the basic we can do. Japego is one of them, USID. Dr. Forsen is here. He brought us some funding to partner with EMSOG to do BEC. We also move into other areas. We are getting some funding, Korea Foundation to build capacity in emergency care. And we need to get that partnership. Locally, we are also doing local partnership. Now, National Ambulance Service, my office is in the office. Anytime I go to an ask and CEO, what are we doing to expand access? How are you doing to expand capacity in the area of, because there's nothing like EMT's emergency physician. It's a pool of emergency response team. And then, so if you're having issue with capacity, let us help you build. If I have issue with logistics, recently I was doing emergency training. He brought me all the mannequins I need. That's the partnership. If we are going to do emergency training at the regional level, I expect to have that partnership also at the regional level. So he support us. Welcome, sir. Sometimes if you are even eating and you have a call, you can stand up with the call. The president calls you and you are sleeping. You get up and say, Honorable sir, His Majesty. When he has a call and I'm in the office and he stand up, I know he's either the vice president or some minister calling. He will stand up even if in his own office. That's why. Welcome, sir, Prof. So, apart from the education, the clinical practice, we need to be at the forefront. I'm happy Bonnie is here. You're going to talk about our emergency response during outbreak, public health emergency. Where I sit, I see public health emergency with clinical together. So when COVID came, I remember I called OKD and they said, Charlie Lawrence, our place is choke, our place is like a COVID center now. I said, yes. Because when people are dying, it's emergency, they will go. They don't know whether it's an infectious dying or it's an accident. It's emergency, they will go. And it was the same thing. I found myself leading emergency COVID care because I was an emergency person. And that's the first point of call. First, they won't come as in a treatment center that you go. They will come to the emergency, either unconscious or they are hypoglycemic or lethargic, or you have to, before you realize the COVID patient you are managing. So his department then became COVID center, and there was a whole issue. Ventilators were, Prof. Anjokusi is here. We have to see some of his ventilators, convert some to COVID. That's the clinical care. So we need to be at the forefront. So Ghana Health Service now, I told Anefia, I know you join us, that we are going to besiege the public health area. Because you can't leave it to the surveillance people, because they can't manage the case. They only go and look for the trouble for you. That is surveillance. And they bring it and say, you act. So until we understand them, we will always prepare our emergencies, both for public and then also for clinical emergencies. And so we have to be at the forefront. Konfanoche is doing some good work, making sure that we are strengthening our front line. And beyond Konfanoche, now Kolebu, Rage, and other places are also doing well. National Ambulance Service is part of our clinical strengthening. We cannot move without them. I remember when we had COVID-19, we designed a system. I was with the CEO and the former DO, I call him DO, Bridjan. Bridjan said, Lawrence, when we have outbreak and you're moving patients, we don't transfer them or we translocate. I say, you are here. So we have to change the book to translocation of infectious cases. You will teach me, every time you are teaching me something. So we need to partner them. Because it's not only clinical emergencies that they respond. They also respond in infectious and outbreaks response. And then the scope of our work must be known by each other. I don't think that we should harass EMTs when they come to hospital. They also harass us when they see us at the pre-hospital area. You call them, they won't mind you. But the good thing is that for some years, I've developed that partnership with EMTs, that I almost know everybody who is responding to a particular area. Because why should EMT be harassed in a facility and a clinician, you fold your arm to see the person being harassed? I won't allow. I won't allow. As a head of clinical service in Ghana Health Service, I've given them that if you come and say, I'm taking your trolley, I say, my friend, give their trolley to them. That practice, maybe Kolebu will talk to you, you also have to stop. Why are you taking the trolley? And the whole ambulance is sitting down and the CEO is telling me, hey, Lawrence, people have taken our trolleys. You can't take anybody's trolley. Look for your own trolley. We need to let them be mobile so they respond to other emergencies. Otherwise, he lock them up. I'm talking for you, and also. Uh-huh. All right. I think my time is almost up. I'm just talking to us, friend. This one is not plenty matabia. So we have to also have tax shifting. This is how, what I was talking to OKD and Chris, that, the formal training is what we are aspiring to. But informally, how can we build capacity so that in the midst of the challenges, some nurses who have not gone to the formal specialists, becoming a specialist in EM, can also be contributing to the care. And then you keep on giving them certification every 2 years because you keep on training them. You don't train them once and leave them. They'll become quacks. And so we have instituted in Ghana Health Service 2026, every staff in Ghana Health Service will do what we call primary emergency care. And you'll be doing CPD 2 years. If by 2 years you haven't done it, you can't get your pin to revert. That's the reason why I'm here with all my suit to engage. Because we need trainers at every region. And it's taking up 2026. A letter will come, you will see. Every health person, you have to do some form of training once in every 2 years. If yours is even learning CPR, it's enough. We call it primary level. Some people will do comprehensive. Those who are in the emergency rooms do the comprehensive. But those who are pushing trolley, those who are reading the compound, they should all know CPR. Is that also? So that we start thinking emergency as a country. They think emergency is only for some small people being in the emergency room. And when they're trouble, they are calling, okay, they won't let him sleep. Everybody should be in the soup. Task shifting will come. Then standard protocols, as I said, we are working on it. Ghana have emergency policy and guideline, 2012. 2012. Okay, if you say 11, what I saw was 12, but if you say 11, fine. It tells us so many years ago. The trick is that in legal practice, until a new protocol is done, the old one still is functional. That's legal practice. But then, if you move to another level, they say, a protocol has to be reviewed at least every 5 years to catch up the current trend. So the baseline is there. I assume we have something, but I'm telling you, by the close of this one, OKD and Chris and Prof. Nyame will tell me when the new A&E policy will start. We are starting to start it from here, the review. Because we need to get it. We started referral policy review. We did it, nice work. Now it's at the policy level. One minister signed, the new minister has come, he has to change the signature. And then I have to put 24-hour economy in the, in the referral policy. So the policy is, we are already using it, but it hasn't been signed. And so we need to move now. Now we move, we carry it to ourselves and we will sign. So A&E policy, standard protocols will be reviewed. My time is up. So we'll work on that. Professional societies will have to help. EMSOG, please, we need you. Come and help us. Oh, sorry. So what am I saying? I think I'm only going forward. I don't know how to go back. They didn't teach me. Okay, at my level, governance and policy, we need to have strategies. And this, one of the things is to engage people in academia to look at how we can focus on local innovations and efficiencies. Very, very important. Everybody here, OKD goes to places to teach outside and come. Every international team has exposure. Chris will go, CEO will go, Prof. Nyame is going. Why can't we bring it here, have a local innovations? Always the issue is that the first barrier is financing. So you need to have sustainable financing in emergency response. Very, very important. Until we have that, we will go and learn. We can't have local solutions. We need to strengthen our monitoring and evaluation structure. Ghana has something, structures that we used to do. Rita is here, the director responsible for clinical service Ashanti region. Rita, I haven't given them wave. Rita is here. He has structures. Supportive supervision, peer review. These are all structures we use to monitor protocols and their existence. We will continue to do that until that people will sleep. Integration, regional leadership, sustainability. This is where the funding is. If you have issues. So my three, just to end up, the conversation will continue anyway. We need to really expand our postgraduate training, and that's what Ghana College is doing now. We have a signed MOU with Ghana Health Service that some of our regional hospitals can start emergency training. And so that we can cover, as we are training, we are also giving care. We need to invest in digital coordination. I don't know if you have what in is here. It's hard time that Prof. OKD, Prof. Nyame, I always call them, should be having a digital access to the flow of emergency. So that EMT will not move from one point. I think they are also doing their own thing. And get there and say the beds are full. You move from Cape Coast to Confranchi. Confranchi, they normally don't say the beds are, but nowadays you are saying it. I've been hearing that. The beds are also full. We too, we are full. We too, we are full. At first we were not full, but now we too, we are full. There must be a system to monitor availability. A system to monitor where trauma surgeons are located, where neurosurgeons. So you don't run to Ifeanyi Kwanta and say there's no neurosurgeon. So move from Ifeanyi Kwanta and come to Winneba. So a system monitoring, digital system monitoring linkages with ambulance is a challenge to us. And I think we should look for solution. Ambulance system, national ambulance, we should never move without having that linkages to see availability on their dashboard. Apart from the communication that we also have to do. So, and we need to strengthen community awareness. And this is the aspect that the CEO is speaking of. Community awareness, pre-hospital care. People becoming responsive, schools knowing how to even do CPR. Our community, we are not aware. I heard yesterday, Rita, that somebody has parked a car, people have died in for 4 days. In the Ashanti region. Is that also? Car is parked, nobody's even bothered to go and see what was inside. Car has parked there 4 days. It says shoe factory somewhere. If you don't know me, I'm telling you. Shoe factory, people, they open it. After 4 days, car has been parked, the human beings have died inside the car. So we need to be aware of our environment. And then the emergencies involved. We need to build regional training hubs. We need to expand ambulance services. We need to increase hospital bed capacity. Very, very important. No bed syndrome. It's about system failure. It's not about the bed. Because no emergency has enough beds. When the system fails, you always say there's no bed. We need to do continuous training, public awareness. I think I've mentioned some of this one. Thank you very much for your attention.
Are there any questions for him?
I do. So, Director, I looked at the Ministry of Health website. Okay, my name is Kokunyami. I'm an educator. But my question or point is, I looked at the Ghana Ministry of Health website. One of the most important documents there is a document on health for wealth, which actually gives a perspective on the policy or the guideline for implementation of health policies in Ghana. I looked and I searched through the whole document for a direction for emergency care in Ghana, and I couldn't find one. Because that's the policy directing the ministry on how to spend money and where to put money. And I couldn't find one. And that's, again, I looked for a policy on emergency care in Ghana. And the only one I came across was October 2011 one, which is a guideline. It's not actually a policy. If you know the difference between a policy, no, it's a guideline. It's not a policy. The difference between a policy and a guideline is that if it's a policy, the government is mandated to spend on it. But if it's a guideline, he chooses to spend on it. And so my question is, where do we stand as a country in terms of supporting emergency care? I'm privileged, I have info into, I'm saying this broadly because the National Ambulance Service suffers the same problem in the sense that there's no dedicated funding, and even funding which is stipulated in law, the National Ambulance Act, is still not available to them. You understand? So where do we stand as a country if we are really thinking about emergency care? Because there's no plan to support emergency care. I understand you have done the scoping assessment that has brought up these challenges. But since it's not in any policy or any directive guideline, how are we going to move forward? If you talk about funding has been a challenge and you have no plan to spend on them, then where would we be 5 years' time, 10 years' time? Thank you.
So I think this question, we'll shelve it for our panel discussion in a few minutes.
Because I think that is fine.
Yes. I have a question.
Hey.
Yeah, Director, thank you very much for the presentation. My name is Dr. George Osu. Yes, I want some clarity on one of the slides. You made mention of rapid transfer is not available to about a lot of the hospitals. So I want to know whether you are referring to the response time or the availability of the service. Yes, the response time. Okay, meeting the response time. On the issue of response time, I think we need to disaggregate the response time because response time for life-threatening emergencies is different from response time for non-emergency cases. So I think that's information, we need to disaggregate that information so that we can get the true value, yes. Because currently we have a global response time for Ghana, which is 25. Let's say, but that's for both life-threatening emergencies and the non-life-threatening emergency cases. Yes, so we need to further go down and then get that right. Thank you.
It looks like this group of communication, it is for the giants in the room to handle. But please, if we have any questions, you can just move to the microphone in the middle. Questions, comments, or contributions?
Okay, so please, I have a question for Dr. Ofori Puedo. A few months ago,
So
if I'm
sorry,
right.
if you could please introduce
Sure.
yourself.
My name is Kwabno Pokwakwa. I'm a medical student. Yeah, so a few months ago, a mate of mine walked up to me that he's thinking of going to a school to train them about CPRs and all. And in our conversation, we just realized that most of us were actually exposed to CPR and these emergency stuff in med school. Prior to then, there was no exposure in our in our basic education whatsoever. And also in senior high or was, I don't remember ever having a training on CPR. And like you just said, a 25 minutes response time, something can happen within that time if a student knows how to offer certain care. And so I just want to ask, what is the structure being put in place to offer training in senior highs and basic schools to allow for everyone to be, everyone to have something to do in this emergency care? Thank you.
You need to respond. So as for Professor one is thesis, so I have to go and sit down and write the thesis. So I won't attempt to answer all. I was just trying to be legally right. If you look at the policy, it says Ministry of Health Accident Emergency Policy and Guideline. That's the title at the back of the book. If the content is something else, you can't come and tell me you don't have. But the back of the book is a brown one. You can Google now. It's a policy and implementation and guidelines. And so Nyame's own policy definition and guideline. I don't want to attempt to. But the good thing is that no matter the level of research you do, once it's validated, okay, it becomes a policy drive for the community, and the national can pick that practice and make it a national policy. So policy does not always sit at the ministry. It's an agreed mapping, agreed timelines amongst a group of people who value, policies are in our villages. So when the chief meets you and says nobody goes to farm on Monday, can I say that this one is not in the policy book in the ministry, or you implement it because it has its own implication. Maybe it's for safety or safeguarding water bodies and other things. So I don't want to be, but whatever we have done at the Ghana Health Service, to us, it's a policy. We start implementing. If you want to make it nationwide, we take it to the ministry. But within Ghana Health Service, once the Director General approves this, the Council approves this, it's a policy for us to implement in Ghana Health Service. So you see, most of the guidelines we write is for Ghana Health Service. It may not be for the whole Ghana. But I'm telling you, other people are copying it and using it. Maternal and child health books. It's not ministry doing it, Ghana Health Service. We all use it. So it depends on where you sit and you say policy and guideline. But that one is fine. Therefore, Kwabena, your question, CEO will answer. He has a good news for you on training basic schools, senior high schools, and even universities on what we are talking about, basic emergency care. They are now doing community. You come and he will talk, ask him plenty of questions. They are doing community now. And they will move to the schools. And we are also meeting them halfway as a service. Certain levels, senior high school, tertiary level, we meet them and then we work with them because we also have infirmaries and emergency response in there. But National Ambulance System has a whole project for the few years to build capacity on that. For Dr. Owusu, he responded to the delay or what we thought. It wasn't availability of ambulance, but about the response time. I think he responded to it. So to us, wellness and health policy, that you didn't find emergency in there. Now, the trick is that I was even talking to you about, normally we quote public health emergency. Go and see, you find public health emergency responding there. But you don't see clinical emergency. Because public health emergency is always thinking it's infectious diseases, it's surveillance, or it's NCDs, non-communicable diseases. So why haven't we seen emergency care? And so the policies are normally broad, but when they bring it to us, we tease them out into agencies and we fish out what our priorities are. So I haven't read through the full details of the wellness and the health thing, but I know our midterm strategic plan at the ministry that we are using to work, it has a 5-year span. Emergency care is also in there. Non-communicable diseases, hypertension, diabetic response, emergency response are all there. They are encompassing in different angles. So maybe we will see how we can tease out ours and project them. I think those are my few questions.
Thank you
the
very
rest,
much.
meet me at the discussion level.
Thank you very much, Dr. Oforebuede. Please, I think we have one more question.
Okay.
I'm
then-
Seth Kojo Usu.
Yes, let me briefly speak on the emergency at the school level. Yes, so as you all know, we have emergencies within the community, emergency care during the community, emergency care during transfer, and the emergency care within the facilities. So for emergency care at the community level and during transport, that falls within our domain, pre-hospital. Yes, and I'm happy to tell you that the President of Ghana is very much interested in strengthening pre-hospital care. And we have started with the community medical first respondents, where we are training about 6,000 community first respondents. They just completed their training. They'll be deployed next month. So the next phase will be the training of students, church, like the general community. So as and when we get the funds, we will start rolling out the program. Yeah, so that's what I want to tell you. Thank you very much.
Thank you very much, Dr. Usu. So please, you can go ahead and ask your question.
I'm Seth Kojo Usu. A paramedic and health and safety trainer. I work with EMSOG Ghana. I'm in charge of first aid for the company throughout Ghana, and also responsible in training the emergency response team. I've gotten an opportunity of engaging some health institutions, training institutions in Ghana with practical first aid. And these are my observations. I don't know if the director has a plan for health institutions, training institutions, in order to carry them along. What I realized was, number one, their tutors. Most of them, they just pick anyone to go and teach that subject. No. First aid. Regarding first aid. Yes, regarding first aid. That's what, yes, that's what I've realized. And more importantly, all the institutions that I've visited, they don't even have full resource for practicals. So I don't know whether the director has a plan for them. If indeed next year the service is starting the primary emergency care for health workers. Thank you.
Thank you very much. I think before director comes in, we'll just polish up a little bit. Please, remind our housekeeping rules. If we can keep phones either on silent or switched off, that would be very beneficial. And the washrooms are on my right and to your left. But to help with the ease of movement, you could either use the back of the room or go out this door and go around. Thank you very much. So please, Dr. Oforebuede.
All right. So when I mentioned training, I jovially said the dean is here because I know I'm going to meet him here. We are going to have a deal where the dean will start training, doing lectures of emergency medicine and in medical schools. Then we have lecturers, so plenty of them. And the school for us, will come and teach. We need it. And then the residents will push. Professor Nyame, go and tell Professor Dano, we should do rotation, surgeries, medicine, all do rotation at the emergency. That's the conversation, that's the advocacy level. Once we sell to the dean, he will discuss it and look at, okay, bring me lecturers. I will create the syllabus. Bring me, and then we move on. So as you said, it's partnership. We need to partner. We need to look at the scope of what they are teaching there. To be frank with you, what is there Universal health coverage, this thing we are mentioning over here, Dean, with all due respect, I've gone to one training, it can't be KNUST. What our seniors, because as for doctors, everybody above you is your senior. Once medical school finishes, our seniors are teaching. It's something that is not addressing what we are also, policy people are talking about now. You see, because I know they reviewed their curriculum, but the current trend of challenge is that how can we all improve quality to address universal health coverage? Period. Ghana 2030. It means everybody, academia, education, we must all work towards it. But still, others are going this way, and other people are also moving here. And so, anywhere I have opportunity, I talk to ministers and directors and tell them that if you all look at the universal coverage, the SDGs, everybody has a role to play. Pick yours and run away with it. You meet us here at quality. Quality will improve, and then we will achieve it. And so we need to partner. Many Ghanaians are too strict to government-owned issues. National Ambulance Service CEO is here. One of the things he told me was that he's going to make sure that all the service provided, whether they are mining companies, service, emergency, you have to be brought under the umbrella and then work together so that we can also support training institutions with curriculum. Because some of us or at your level can go and teach as a part-time. Prof Akusi will tell you. You don't have to be a full-time. Once you meet the criteria, I've taught in Central University for 10 years. DJ should not hear this. I teach emergency medicine at Central University, and I teach PAs over there. It's a part-time. It's not Galamsey, it's approved. Because I realized that since 2013, I was the only emergency physician at the corner there called Tema. And that's where the school is. And so when I went there, Prof. Zakaria gave it to me. He said, my friend, I can't come from Accra. You are in Tema, take it. And I took it. And I do it flexible. I don't have any sweat. When COVID came, we were even doing online lectures. I go there once every week. But I make sure that the time I spend there, that 4 hours, I put to them the wisdom of emergency. And so we have to partner and look at the curriculum, and we'll build it together. I'm sure whatever you want them to know, the system will capture it, refine it, and set gradually. It will not come boom. It will start gradually, and then you'll be able to feel your presence and then what you want to impact. Thank you very much.
Thank you, thank you, thank you.
Just as a comment on that, so it beholds on we, the institution leaders, to choose the right people to do the right things or impact the people. So like he rightly said, if you want to teach, people think that emergency can be done by anybody. You get my point? And so anybody else can do it or can teach it. And like Dr. Frobody mentioned earlier, before emergency medicine started, actually, people were managing emergency problems. So they feel that it can go on that way, but there's a change where people have been trained to do that. And so we, the institutions, leaders, should choose the right people to do the right things. Especially, one of the gaps we have actually identified is we have Ghana College of Nurses and Midwives for postgraduate nursing, Ghana College of Physicians and Surgeons for the doctors, right? We have the degree. In fact, KNUST have a degree emergency nursing and MPhil emergency nursing and critical care. You get my point? But then at the level of diploma nursing, who teaches the emergency there? The general nurse. Do you get the point? Without a specialized training in emergency medicine or emergency nursing. And I think that's what he is bringing out, that we need to look at how that happens so that the more trained persons can be the ones instructing those at that level. And I think that's the gap actually to be filled. So the heads of institutions can actually look at that level. I know for our EMTs, we all play a role in the training. In fact, the community training, Chris was leading it. You get my point. So it's something we are all enthused about and will be happy to do. It's about contacting the right people. Right, thank you.
You can move to the microphone.
Thank you, Doc. So in that regard, are you suggesting that there should be a certification or certain program that someone should pursue to be able to teach emergency or teach CPR or BLS outside? I would like to ask that. For any certification, are you recommending that?
At this point, I will want to stay away from a paper called certificate. But the skill and ability to do it is what's important here, so that it doesn't become a cult in a sense, quote and unquote, where only a certain people can do it. But then, if I am the head of an institution and I'm choosing somebody to teach emergency nursing, or I'm choosing somebody to teach first aid, or I'm choosing somebody to help CPR, I should be confident that that person has the skill, competence to do that and to transfer that knowledge, not just a general practitioner. In terms of CPR, there are people who don't have emergency medicine or emergency care big background, but have BLS training or ACLS training, and are instructors. Do you get the point? And so they have that instructor, if you like, qualification, status, and so can also teach the content which will be CPR. You understand my point? So I will not be limiting myself to a certain group or a certain certificate, but then the general competence of the person to do that.
As for me, we are doing certificate. If you're on the field, it's different though. If you're on the field, people want to show evidence of training. So,
Not the trainee, I'm talking about the trainer.
We are still training them. That's why Beck you were doing trainer. Okay, this year we were doing trainer of trainers in Beck. Is that also? I got to a time I was a provider. I moved in. You told me I should do about 4 or 5 training before I become a trainer. Is that also? So why don't you do same? People who are practicing want to show evidence that even in developed countries, prof is here. If you don't have evidence of ACL or BLS and you're working in a hospital and there are issues, you see the legal issues that are going. You may be an emergency physician, but they will ask you, where is your ACL certificate? So we must also let people understand that certification is a legal entity. Sometimes the hospital will brand you, they cover you in the hospital. Once you practice in the hospital, we cover you. But when you go to court, it's individual skill and individual competency. That's why the court will ask you, have you even renewed your CPD or your PIN this year? I've been to court several times because of legal practice. You think that you are working in Confanochi and you don't go and renew your PIN. And when there are issues, a small lawyer, sorry, don't quote me anywhere, will ask you, Prof. Kusi, this year, have you done your GMA or the Ghana Dental Council certificate? Prof will say, yes, my lord. That one, you take one box. You will be telling him and say, no, this year I haven't done it. Hey, then Prof, do you know it is not professional for you to practice as an assistant? You don't know. So we have agreed as a service that we are going to train people to become trainers. And then when we have people who are certified to train them, we also certify them as trainers. Everybody will train you will become a provider. You become a provider. So that when you are in occupated emergency room, you are there in charge, and there are issues, they ask you, what emergency do you know? You say, my emergency is here. If you don't even know this, look at the certificate. I also go through. To us, it's a motivation. So let's think together. Don't let certificates scare us. It doesn't scare us any longer. People want to be pompous that I have done CPD in emergency. This is my certificate. Even though I'm not an emergency physician, somebody has trained me. Who are the trainers? Oh, Prof. Nyame was part. Then it's a quality training. So let's all think through. And I think legally, you must be trained to perform. If you're a doctor, you don't go to CPD. You can't be performing with all your due respect. So let's see evidence of your capacity building certified. And then you go on. That's what we are doing. 2026, before we train people on basic emergency care, we want people who have been trained, certified, go and train them. And they will also train them, give you certificates. Me, I will sign. DG will sign. You are a provider for 2 years. Is that also? Thank you very much. We will discuss.
Okay.
Thank you so much.
Okay, so I'm not done. Just a follow-up. There's more. Okay, so this question goes to Dr. Wodi. I would like
Ofori Buedu.
Sorry, Dr. Ofori Buedu. I'd like to find out, is there any specialty program that you recommend to the EMT fraternity or the professionals to pursue so that we can also be in line with what is being practiced internally?
Your CEO is here.
Because
So I think the question was to be directed to Dr. Owusu as the CEO of the National Ambulance
The
Service.
CEO has a lot of things he's discussing with EMSOG and everybody to come on board. I know this answer he has. I won't answer for him.
Okay.
When it comes to EMTs, I support training. I don't control EMT.
Okay.
But he's supposed to make sure that the policies and the guidelines are available and people who are qualified trained you. Is that not so? So don't worry. After here, we'll talk. He has come.
Okay.
Yes.
Okay. Thank you so much.
And I think there'll be a separate section. Yes, exactly. So the CEO of the National Ambulance Service will have a session tomorrow. So we hope to see all of us here so that the conference can continue. Once again, we are all welcome to the second Emergency Medicine Society of Ghana conference. Our theme is Strengthening Emergency Care, Local Solutions for a Global Impact. The third session that we have is a panel discussion, and it is bringing together giants, for lack of a better term, in the healthcare society in emergency here in Ghana. We looked high and low for the best person to moderate this panel discussion, and we thought the only person who could lead this discussion is the faculty chair of the Ghana College of Physicians and Surgeons for Emergency Medicine. For those of us who may not understand, he's the headmaster for all doctors who want to undergo training in emergency medicine. So whether some of us will pass or not, all of it is up to him. Please, to help me pass my exams, please let's give him a round of applause as we welcome Dr. Nyame.
Thank you very much. She said I'm the headmaster. If I am, then Prof. Njikusi is a principal. I will, forgive me, I will change the program a little bit before we go on. We are supposed to have the panel discussion, but we have one of us, the regional director, ICD, with us, and she has to attend to other equally important engagement. And so we have a few minutes for her to give a remark, and she can leave us, then we will continue. So just please, let's welcome Dr. Rindolph.
Good morning. Thank you, Prof. Nyame. So my name is Rita Larson Rindolph, and I'm the Deputy Director for Clinical Care, Ghana Health Service, Ashanti Region. So that's my boss, Director Ofori Buedu. So when you go to headquarters, it's Institutional Care Division. And then when you come to the region, it's Clinical Care. So I'm here on behalf of the Regional Director of Health Service for Ashanti, Dr. Fred Adumako Boateng, who is in Accra for a newborn conference going on. And we are also training clinical mentors for Ashanti region at Golden Bean. I left there thinking that the opening ceremony was in the morning, so I need to go back to facilitate. So forgive me for that. So I acknowledge the presence of the Dean of the Medical School, Prof. Njikusi, and then my distinguished colleagues here, and I can see a lot of emergency medicine champions here. Good morning once again. And it's an honor for me to be able to join you, even as you celebrate your second EMSOG conference. I can see the theme there as strengthening emergency care, local solutions, global impact. Emergency medicine has come a long way. When I finished medical school, there was no emergency medicine discipline. So you don't go through any rotation in emergency medicine, and then you are put on duty at some place called casualty, and you are scared. So when you are going, you are looking for your colleagues, and they will duty with him, and then the casualty, why, bra, beboame. And then you are there, and somebody comes, and they have some laceration on the scalp, an RTA, no triaging system, nothing. So I believe that we've come a very long way. we know that emergency medicine, time makes a lot of difference, right? So for me today, I believe that two things that I want to leave you with is leadership and collaboration. It's taking leadership for Ghana to set up this emergency medicine training at the postgraduate level. And we need that same leadership to continue, okay? When I say leadership, I'm not referring to titles only. I'm talking about the courage of a nurse, okay, at the emergency department to call out and say that this is the protocol we need to adhere to. Courage for the EMT personnel to advocate or call out for better equipment in their ambulance. Okay, that kind of leadership. For the heads of department, the physicians to say that let's innovate. This is the way we should do it so that it gets better. That's the kind of leadership I'm talking about, and not just the titles. Okay. But leadership also means that you recognize that you cannot achieve this alone. And that is why you need to collaborate. The specialty itself was birthed through collaboration with University of Michigan, Utah, and all those. And so if you are going to sustain the gains that have been made, it will take collaboration. So for the time that you are spending here, I will say that connect with one another, okay? Exchange phone numbers. Some systems and solutions will come through a conversation with the person sitting next to you, okay? And then commit to something, at least one thing, before you leave here. Commit to something that you want to do. That is also showing leadership. And then let's continue to communicate. So the emergency care we desire may not happen in one day, but it will certainly happen. So I wish you all the best in your deliberations. Thank you.
Thank you, boss. Very, very much thank you. Collaborate. So when I came in the morning, I actually told one of the organizers that I don't like the sitting arrangement. And I still don't like it. It looks like one group of people is here, another people is here, and another set is there. Let's collaborate, let's mix up, let's interact, and then it will be fine. Thank you very much. So we are going to have a panel discussion from classroom to command, building the spectrum of emergency care capacity, integrating education, clinical practice, and governance. As we all know, emergency care is a systemic thing that needs to be integrated together as one component by education, clinical practice, and governance integrated into one unified framework. There may be gaps, or there are gaps, so we are going to have a panel discussion. We have people in education, leadership, governance, that will help us do this discussion this morning. To start with, I will introduce our guests. We have 3 panel discussion members. Our first panelist is the Dean of the Medical School, Prof. Nchukwusi, Associate Professor at Kane University. Prof. taught me as a medical student, as a resident, and even as a fellow. Prof has passion, even though he's an anesthesiologist, has played significant role in the development of emergency medicine in Ghana. Indeed, at some point, he was our head of department at the Confanoshi Teaching Hospital, Accident and Emergency. I can't read all the things about him. So with a round of applause, please let's welcome Prof. Nchukwusi. Thank you. The next person I will call is the head of department for emergency nursing and critical care at the KNUST, Dr. Amoba. A whole about 10 pages, forgive me. Let me just summarize as a doctor in emergency nursing, published with leadership skills. Please, let's welcome Dr. Amoba. The last person we know already, Dr. Lawrence of everybody, as you know, he passed through the training and now at the top commanding. So, like you are aware, in terms of policy at the national level, he kind of sits in as a clinical care person. So, panelists, thank you and welcome. I am your moderator. Microphone. Can you have another? Okay. So, Prof, let me start with you. So we go through education, medical, okay, that's fine. Thank you. Medical education, nursing education, and suddenly have to find ourselves as leaders, both situational and positional. What are the real challenges that, and I'm sure you have gone through that as a person. So what are the challenges that really come up in that transition process from a student to a leader?
From a student to a leader, the challenges that one goes through. The point is that when you are in school, you are looking up to someone to take commands. Do A, do B. You are not responsible, so to speak. But then, from the school, once you transition and coming up into a leadership position, and in fact, if you're a doctor, for example, wherever you find yourself, you become a leader. So we've seen some of our students who have just qualified, they've done their house job, and they are leaders in hospitals, medical superintendents. Now, the challenge is that at that point, you are in a position of responsibility. But in medical school, in teaching, that is something that you do not appreciate. In fact, we don't really teach you to become a leader. So as we've mentioned here, we are revising our curriculum. So if you are a medical student, for example, what is expected of you? So now the emphasis is on competence-based teaching. Whatever we are teaching, there are some competencies that you have to acquire. And one of those competencies is leadership. Someone has to lead. And no matter who you are, at a point in time, you're going to be that leader. But because we don't put you through right from the beginning, it's like you're always looking up to somebody. You want to blame someone. This one didn't do that. This one didn't do that. What are you able to do? Okay? So, competency-based learning. Now, when you are teaching you anything, whatever you are teaching you, say, what are the competencies that you have to acquire at the end of this topic? And one of them is leadership, advocacy, communication, etc., etc. I think it's some of the challenges that we face.
Okay, so if I get it, it means that now the curricula is being reviewed to add some level of competence in leadership at the medical school level.
Exactly.
And I think I can actually align with that because we have actually also reviewed our curriculum for the residency to actually include taught courses in leadership. So I think it's becoming a known thing that you have to teach people to lead, right? Thank you, Prof. Dr. Moba, I'll come to you. Now, looking at, from the perspective of educationists, looking at what we teach in the classroom and in practice, do we see gaps, as in educating people in the classroom and actual practice in the clinic or in the field? Are there gaps, and how can we adjust our challenges, and how can we adjust our educational system to meet these challenges?
Yes, so thank you. Yes, and a good morning to everyone. Yes, so for emergency medicine and nursing, because I'm coming from nursing perspective, to have the greatest impact, then we must design our educational and training this curriculum to where these emergencies occur. And then let me first say, let's look at the realities that we in Ghana face. We know that most of the emergency cases will present first at lower level, but not at the teaching hospitals. A teaching hospital is later. And then we know emergency medicine and nursing is young. We have Dr. Chris as the pioneers, some of the pioneers. So it's a very young specialties. And we also know we are in a reality where we have a shortage of resources, shortage of other things. So that means our curriculum are supposed to be designed in a way that will take care of these levels. So we have to re-anchor our curriculum designed to cater for outcomes that are focused at the CHIPS, at the district hospitals, at the health centers. So these are some of the ways that we can look at our curriculum, to look at things that reflect our situation in Ghana. Our disease burdens, we know trauma, road traffic, accident, and now there are growing incidents of what? NCDs, stroke, MI are some of the burdens that face us. So we need to reorganize our curriculum to reflect these our growing issues.
Okay, thank you, Doctor. So, in essence, we have to look at our disease burden and where they occur most, and train our personnel to be able to address these challenges. Would you say it's occurring, as in we are able to achieve that, or to some extent?
We are not able to achieve that, because if you look at reports, there are several burdens. And I'm happy to see our national ambulance, though now we have the wider coverage of national ambulance, but we know the usage is low. Okay. People come into our emergency department in private cars, in taxis, and other things. So we haven't yet reached there, but with the revision of our curriculum and training of the middle level care providers like the PAs, the nurses, will let us reach there. Maybe not soon, but with time.
Okay. All right, thank you. Dr. Forward, I will come to you this time. I will go back to your presentation where you spoke about the universal health coverage. So somebody has to hold everybody in place. How do we, as a country, and I actually personally feel that emergency care is a low-lying fruit for universal coverage. Because if you're able to actually have efficient and effective emergency departments across the country, you can easily achieve equitable, accessible health for all, which is quality at the same time. So who do we think that in our setup would hold the fort, who put the pieces together for us? How do we achieve that?
All right, thank you very much. In fact, if you ask who, is all of us here, all of us in this room, we are all responsible. Because if you really want to implement our strategies, it doesn't come from the person who sits at the top as a minister. But the best strategy is implemented at the implementation level. That's facility. How many of us are really even bold to say that we are EM nurses? Therefore, when my in charge put me to go ahead OPD, I should be able to convince her that I want to be at the emergency room. I've seen critical care nurses, emergency nurses, who are not working in the emergency room. Because now he's now a deputy director of nursing. So he has a very nice berth. He has been moved from emergency room to administration. And it's very comfortable. Yes, now I'm the director of nursing. So we all have to be responsible to be proud to go back to our room and build a system. Very, very important. Because we can't leave it for the few doctors or the few specialized nurses, specialist nurses or few specialist EMTs to do the work. We all have to do it. So as a leader at where I sit in policy implementation and development, one of my duties is to come to you, advocate that this is what we are discussing. How can we all hold our hand and make it loud? Because until your voice is heard, until your action is seen, you will not be given budget to do anything. The budget, as you said, resources are very limited, and priorities are there. That's what the director was saying. She was saying that if I have money, I will do all this training. Have you seen the caveat? You want to train every school, but it comes with limited resources. But the limited resources that those who, if you are able to do advocacy, I was comparing emergency to family physicians. I'm very sorry to say that. Family physicians come so loud in Ghana Health Service that they are managers of all our hospitals. They want to be at the top where decisions are taken. And I told, so now the FER is there, he will come and tell me, every time I'm pushing her, those in Ghana Health Service, let's also get closer to the top. When we are at the top, our budgets are prioritized. When we are at the top, our activities, even if you want city, they'll give you 20 pesos to do it. But when you are not at the top, nobody cares what's going on. They only say that emergencies, you don't generate money. You only spend money. And so I believe that the onus lies on us. Let's take this advocacy from today. As we live here, what can we do in our own way to propagate emergency care in our community, in our facilities? Me, I'll talk to the academians, the OKD, the consultant that help me build the guideline and SOPs. When I have it done, Minister signs, I send it. That is what I can do. Getting policies, getting guidelines, disseminating them. But the implementation lies on us. Because the guidelines will come to your facility. But if the one day cannot pick it out and implement it, it will continue to drag. I think the year for action for emergency is now. I told Prof when he came to me that I want emergency people to also visit. I also visit you. Now I won't even wait. 2026, myself and CEO, we are visiting you everywhere. so that you help us move. And that is the way we have to go.
So, if I to summarize what you said, we need to play advocacy so that our voices will be heard, and then we will be given money to do. No, so yes, the fact is that, well, we all know, it is a fact that you either sit at the table to eat or you are eating. You know, so I think the point is that we need to be sitting at the table. In line with that, so it comes to the point that, so if we want to get allocations for expenses, then we need to make noise.
Not noise.
No.
We need to be loud. Loud may not be noise. Noise is nuisance. Where Prof. Ankusi sits now, emergency is linked to him. He cannot run away, even though he's an anesthesiologist by background. What are we using Prof to achieve as he's a dean of medical school now? Number one. So let's convince Prof, visit him often. Prof, the curriculum must have emergency medicine in the medical school. Before he leaves, he has said that for us. CEO now is emergency physician. What are we using him for? CEO, we want emergency training, EMTs to be professionals now. Certify them. Don't let them be a nuisance. Make them attractive. We are going to support you as an association to make sure that these standards are met. What are you waiting for? Why I said I'm not too big a boss. He's a CEO. I'm a director. So some table he goes there, I don't go there. What are we also doing? So I think these are the things. There are people at the academia. Chris is the head of department, OKD. What are you, where you sit? Ghana College.
The headmaster.
So we have people at critical positions.
Yeah.
Nanefia is a head of emergency at Rage, where the noise is always made. What are we using her to achieve in Rage? That you said that, oh, now emergency care has come to stay. These are the people that we have to use them, make the advocacy. And then they will look for the opportunities, and then we will bring our knowledge, and we will make them. So I think that's what I'm calling for.
Okay, I actually understand the point, but then the next level I want to ask is that then who do we hold accountable?
All of us. All of us, we have sat down for quite too long. We have been so gentle quite too long. We find out the emergency room, we close, we don't even talk to CEOs, we run away, we are tired. Now let's have time. When you close, walk to CEO's office, go to him, tell him. It's not always complaining about what's not right, but telling him what ought to be done. If he always complains, he can't face it because the limited resources are not, he can't face. But tell him that, CEO, now we want to have a digital dashboard at emergency that when I click, I know all the service. So anytime I feed them information that EMT will not run here, we say no bed. This is a small innovation that can be fixed. But if you go to CEO, we don't have beds. We do, our beds are broken. CT scan is broken. It will get broken. But get them EO's innovative way of getting now it's partners. You can't get the money from the Confanoche, but partners can come and build a dashboard that Chris' office at a glance can know where emergency is practiced, where their EMTs are located, what are we doing. That's what I'm also building at my place. So we can always link up and we talk. That's what I'm talking about.
Thank you. So I am the moderator. I'm allowed to deviate from my part.
So I think I've finished answering my question.
Panel, I'll indulge you small. So CEO, he mentioned about certification for EMTs. What's the plan? Is there any plan? An ambush, I know. I can ambush. So, I mean, I understand from my little knowledge, I know there has been certain steps taken. So, for EMTs, and I think one of the gaps we have as a country is the fact that there's no governing or governing body for pre-hospital care in Ghana. Like we have Medical and Dental Council, Nurses and Midwife Council. There's no governing body that regulates pre-hospital care, and so it's more like a free range now. So, what's the way forward for us?
Yeah, so thank you very much, Dr. Nyame. On the issue of certification, as far as the training of EMTs are concerned, we've come a long way. We've come a long way since 2004. We have positives, but unfortunately, our training school is not accredited. So the certificate that we give is only useful within the ministry. I say, yeah, but going forward, I'm happy to inform my staff that we formed a subcommittee of the board to get accreditation from GTEC and to get affiliation with UHAS.
Okay.
Yes. The committee is ready. I think they've been given 3 months. They've been given 3 months to finish the accreditation process. I can mention some of the members. Professor Awuku, who is the Dean of Medical School at UHAS, is a member. Professor Nyame, you will soon get your letter. Chris, you will get your letter. Our Dean of Training and Development is also a member. Najib will be a member of the accreditation. And Dr. Nyaba is also a member. And there's one member from GTEC. So I'm very confident that going forward, we will get certification that's recognized by GTEC so that our staff can build on it.
Thank you very much.
Yes.
Thank you, see you.
But I have a question for, if I'm allowed.
No, I'm asking the question. All right, thank you. So, Prof, I will go around one last time, and I'll come back to you. So, in terms of patient safety and quality in emergency care, how do we position governance in our setup that will benefit the patients?
Okay. I want to go back a little bit to your previous question. Who should we hold accountable?
And actually, that's in line with
Yeah. So, as Dr. Ofoebuadu said, it's all of us. But unfortunately, people in leadership position even don't understand what emergency medicine is about. And you recall that even when we were beginning this emergency medicine program, heads of departments said, no, there's no need. We have been doing emergencies, so there's no need. Why do we need emergency medicine as, But like you rightly said, if we want to achieve the universal health coverage, then we cannot take emergency medicine out. But then the problem is if you have people in management position who do not understand, then where do we go? Okay, so education is key. And I'm happy we are having this conference. It's a form of education. It's rather unfortunate that most of the stakeholders are not here to listen to some of these things that we are talking about. They need to understand what emergency medicine is. What you can do, I will not be able to do because it's a specialty on its own. There are ways to go about it, backed by data, how things should be done. And if you are not there, you will never understand this. And it's a multidisciplinary sort of, a specialty that we need to bring everybody along. So if emergency medicine alone is trying to push, and then the others just sitting aloof, it will not work. I'll give you a typical example of a patient that was involved in an accident at a workplace and was brought to Komfanoche, was admitted to the special ward, and then we're supposed to fly him out of the country. fact, this patient had a chest tube. And then I was responsible for the management to make sure that he was flown safely. Emergency medicine had stabilized the patient, everything had pushed to the. On the morning, I went to the ward early, 7 a.m., to make sure that everything is set for the patient to be transported to the airport, to be flown. Now, the gap. We had left the nurses on the special ward out. So, you know, our training is about emergency. Yeah, they have stabilized everything. I got there in the morning. The nurse gladly approached me and said that, oh, I have emptied the bottle, the underwater seal drainage bottle. And this is the amount that I drained. But when I got there, the patient was in distress. In fact, I nearly collapsed. But I had to put myself together, call the nurse aside, and say, quickly, bring normal saline. Let's fill the bottle. And then, so from there, I went to the in charge and then told her that this is what your nurse had done. In fact, she didn't understand what but she was doing her best. In fact, for her, she was draining it like she would drain a urine bag. And confidently telling me, this is what I've done. So, doesn't you mean? Education. Me, I would say education, education, education. From the top, you don't assume that the CEO who sits there knows what is going on. So we need education. Everybody needs to be educated. We shouldn't assume that, oh, this person has practiced for 20 years, 30 years. He knows about how to manage emergencies. The nurse who is in charge of the ward knows about how to manage emergencies. We just assume. So I'm happy that Ghana Health Service and National Ambulance Services is trying to train everybody. And that's to get to a point that everyone will have to be certified. You need certification that every year or every 2 years, you have this certification in emergency medicine. I think it's key. My point is that education is key. And that will have to start right from medical school, nursing school, wherever, even up to the senior high school. And that's the only way we can achieve universal health coverage. Yeah, education, key.
Thank you, Prof. Dr. Moba, so as academic institutions, for us to influence policy, we actually need data. So, and I know we train a lot of people. We have trained a lot of people in emergency nursing. I saw a communique where the Deputy Minister of Health is asking about data for emergency practitioners. Do we have data of our trainees and where they are and what they are doing there so that we can actually inform policy direction? Thank you.
Yeah, so thank you. So for now, we don't have, because the current emergency nursing department was under the general nursing department. So we have done a tracer study that has captured nursing students in general, but not specific to emergency nursing. So as we have become a department, we are just about 2 years old, we will also look back and then do our own tracer study to reflect our emergency nursing students' performance and then their employability. But you talked of research and data influencing this in policy. As we know research is important because it helps us identify gaps that the systems cannot ignore. So we must always try to do research if we want to find out what is happening to the system. And for Ghana, I know there are a lot of data on emergency like preparedness. We have a lot of studies that have done to assess emergency preparedness, emergency protocols, how they work. But these have not been quantified. And quantifying this will also help the Ministry of Health, the Ghana Health Service, to be able to design protocols that can address some of these gaps that are found. Also, we know our research also produces data, and this data have to be translated into practice. But most of our research ends up a discussion. We don't move forward to recommend actionable, like maybe recommendation. The recommendation that will lead to action. So we need to move further on that. So I think that is.
How can we bridge that gap between what data we have as academicians and actually bring that to bear on policy? So apart from just writing the paper or getting the information, how can we actually make our impact by telling the people who matter that this is what we have seen and this is what you can do?
Yes, I think this should even start with engagement, early engagement with policymakers. So before you even go to for maybe further to conduct the research, you should engage with the Ministry of Health, you should engage with the Ghana Health Services, draw their attention to some preliminary data, telling them what is the situation. And then from there, when they are involved or they feel part of the project or they own it, then its acceptability is high. And we also need to also collaborate with other bodies like Ghana College of Nursing and Midwifery, Ghana College of Physicians. All these are bodies because they are responsible for training. So after you have done your research and you have made your recommendation, they are responsible to train the workforce to be able to do what you have recommended. So before you even start with your research, there's a need to collaborate with these bodies.
So thank you. So if we don't take anything out today, 2 words: advocacy, education, and training. Yeah. Dr. Frobody, I'll come to you last. So we are talking about collaborations. But one of the areas that we can collaborate with is private sector and NGOs, right? So what role do you think the government can play in that to facilitate such collaboration between institutions, government institutions, NGOs, private sector, to enhance emergency care services and emergency education in the country?
All right, thank you very much. Let me just add my voice to the data. You know, everything that we do must be data driven. As I sit here, I sent out a questionnaire to all the Ghana Health Service facilities. That's 9,400 facilities from CHIPS health centers to do some baseline assessment. And I'm looking at the data, human resource. Where are emergency nurses in Ghana Health Service? Where are emergency physicians? And then you can see the CADA. Where are EMTs who have been attached to our facilities? We're tracking them all. And you can see that data is key. Because for us to build...
Do you have them? Do you know the nurse?
Yes, for Ghana Health Service facilities.
You know.
For Ghana Health Service facilities. We have a whole system called HRIMS, Human Resource Information Management System. It tells you every CADA and then how many we have in a region, and then even their facilities, where they are located. So it helps us to realign our facilities and know how to build capacity. So data is very important. For us to achieve the quality and partnership and all the things, and then the private coming in, we need to have a sustainable system based on our data for our workforce. Our people are leaving. That's why I'm saying the data. They are not available, and so even partnership has become an issue. Either to private partners where collaborating so well, but because of the human resource attrition that we have in our system, most of our trained personnel, emergency people, after COVID, they are gone. This one smiling to us, they all have clearance in their pocket. Very soon you see them also gone. So the attrition is so, workforce, we train and they leave. We train, they leave. So it's becoming difficult for us to even partner for sustainability. So at this time, I think we need everybody on board. This data I'm talking to you about is Ghana Air Service. I wish I have data for private facilities. I wish I have data for EMT. But now I have to collaborate with EMT for them to give me their data, private practitioners to give me their data to see where Dr. Irene and co are all hiding. So I know that this one is in private, this one in government, this one in this. Collaboration is very key. Until we have our data set right, we cannot make the impact we are looking for. Once the data set is right, distribution, availability, capacity, then we know where we want to start with our limited resources.
I was going to hide it, but now you have said it, that there's an attrition rate which is super high. What can we do about it as a country?
Give them incentives. The incentives is capacity building. Let the training be flexible. Everybody can hide in the village and still have the qualification. That is number one, incentives. You don't need to go through hurdles of study leave before you get a qualification. I can still be working, and Prof. Antiquisi should be able to have a flexibility that I can still be having some sandwich program there to improve myself. Where am I going? So capacity building is incentive. It's not only money. Number two, the system should be flexible that if I need to move to another level, it shouldn't be any bottlenecks. The system should be seamless. You flow through without any challenges. And number three, what is the future? The future of every health worker here is about how can I get to the top? And then the money is very important. It keeps us moving. But how can I get to the top is what is making them go. Because they have struggled in there. They are not getting any recognition. Nobody sees them. They pick their bag and they are gone. But if the
you don't think it's
comes,
the money sending them?
No, the money is a factor, but that is not the sole motivation. The research shows that those who are going, one, it's about career progression. They feel that that's why CEO, I'm happy is mentioned about certification and progression. If I work after 9 years, I'm still the same, I'm not moving anywhere, I get frustrated. Number two, I want to even move to another level for referral, for transfer. You say you won't give me transfer. You stay here. I can also go to school unless I have study leave. You won't give me study leave. You frustrate me. Yeah. The money, there are incentives. We are working on something called rural incentives. So that those who work in rural incentives.
When is it coming? It's been on the
It has been there, but the emergency people were not enjoying. Now we have to also enjoy. We are all now there. Rural incentives mean that when you are in a village, your promotion should not be the same as the person in town.
Exactly.
So nurses have been enjoying it. When you are in a village, they promote them after 3 years to next level. But if you are in town, you go through your 4 years. You go through your 5 years as a doctor. Let those things go down there so people who are there will not feel the price. Let's use telemedicine to go CPD online capacity. So I don't have to move to Kumasi before I get my
certification done. Yeah.
So these are the things that will be incentives. Above all, money is important. But that is not actually so motivation. People are frustrated, and that's why they are leaving.
Yeah. All right, thank you. Because of time, we will be coming, but CEO wanted to ask a question, so I'll just give him the opportunity.
Thank you very much, Prof. Nyame. I'm happy Prof is here, Doc is here, and Director Furibodo is also here. We all know that the resilience of medical system, depends on an effective emergency healthcare. But over the years, we train our doctors, our nurses around chronic cases. So I'm very happy you are talking about curriculum change to reflect emergency medicine or emergency practice. Yeah, so my question is, you answered my question by the way you answered your question. So I'm very happy. We are going to have that paradigm shift. Yes, to teach our medical students, to teach our nurses, or to train them around emergency practice, and not at least on chronic cases. Yes, so I'm happy. I'm happy that
tell them that
has been
somebody
done.
know that
Chief, I'll not cut you short. Even the way we do a house job now, honestly, the way they put somebody at medicine as house officer, say pass through nephrology, neurology 1 month, cardiac 1 month. I don't know what does a person learn? Nothing. I believe that they should rather put that person at the emergency medicine instead of at the Department of Medicine. They are not learning anything. In fact, the things that the neurology is going to learn there, I don't know if they want to put him at CDM or wherever. That's not what he's going to manage. It's what comes at the emergency. Now, when the emergency has already stabilized and sent to the ward, he came with asthma, all the wheezes are gone, and he's on the ward, and that is what the house officer is seeing. What does he learn? Nothing. So I have some ideas that we will share along the line and see whether Ghana Health Service and the people at the top will want to take it up.
Surprisingly, our place, they do emergency rotation.
So
at Ghana Health Service. I don't know where teaching hospitals, because they do 3 months, almost 3 months.
So yes,
rotation at the emergency.
So I think
department.
the other side is that we, the institutions with the
subspecialties,
should look at having the house officers with us actually. So I know AGA has a place for training for house job, right? My time is up. Concluding remark. So AGA has a training. Rich do. Kolibu, do you do? Not yet. Not yet. So I think we should look at expanding the options for house job actually for house officers.
Expand the training. Let your residents move to the regional hospitals so that they can do the housemanship, can do emergency rotation. When I was in Tema, they were doing emergency rotation 3 months. When I left, because there's no specialist there now they
stopped,
do internal medicine.
Yeah, they will
so
stop,
if the residents found themselves in the regional hospitals and they are doing emergency proper there, the house officers will go there.
So MDC required that there should be a minimum a member at the facility for house job. So I think that would be on us to look at that. And on that note, thank you very much.
Thank you. Right. Thank you.
Thank you very much. So snack time. So we have a snack time now. So we can continue the conversation during the snack, and then we'll come back for the opening ceremony.
So please, we are heading downstairs to the basement level for our snack break. We have 10 minutes for the snack break, so we will move down and then come back up for our opening ceremony. Thank you all very much. So we can head this way. The lifts and the staircase are on my left.